Now I want to draw our attention to adjustments and finding and staying in the green zone. It's clear that the lap band tames hunger and provides patient control in the eye of that perfect storm that I described. It's important that adjustability allows us to adjust for this now and indefinitely into the future. It's a tremendous advantage. Now, I mentioned the total care survey before. I'm going back to the total care survey now and ask what practices are doing about band adjustments. Now, at that survey of these several hundred practices, 88% were performing their first adjustment at 4 to 6 weeks. 93% were using the green zone method of deciding whether adjustments were necessary. And once they decided an adjustment was necessary, 69% used a clinical assessment to adjust the band. Others used barium fluoroscopy. Some practices tend to fill the band up and then back off till the patient can swallow. And others are using experimental methods, using pressure adjustments. None of these have entered a routine clinical practice to date, and I would certainly recommend that we always fall back on clinical judgment and adjusting slowly. Many practices don't use x-rays at all, even to find a difficult to assess port. So I think the key thing from those many hundreds of practices in the United States, 93% are using green zone principles to allow the patients to visualize where they should be. So the key to adjustment is to get satiety, not obstruction. Prolonged satisfaction after a small meal is the mode of action, and the patients need to work with you and the tool and the band as a friend to achieve that degree of satisfaction. When we're going to adjust a band, we need to talk with the patient. And sometimes we're not good at that. We need to be able to hear the patient. We need to know what the quality and quantity of their food is. We need to know about appetite and hunger. We need to know if meals are satisfying or not satisfying. We need to know whether that satisfaction lasts. We need to ask about foods that you can't eat, foods that are difficult, foods that are problematic. We need to really encourage the patient to be entirely honest with us about red zone symptoms and maladaptive eating, eating the wrong things, regurgitation, vomiting, reflux, etc. We need to go into those symptoms carefully and always ask for them. Unless we actually do a thorough job here, we really won't be able to adjust the band adequately. So the key to knowing and keeping the patient in the green zone is understanding how they feel and getting them to understand how the band will help them. How do I do adjustments? Well, I simply do them in a typical office visit. I do them in a typical consultation in the rooms. I don't have patients come in for adjustments. They come in for a visit, and on that visit they may or may not get an adjustment unless it's appropriate. I don't call them fill visits. I review their diet, food choices, eating patterns, physical activity, comorbidity, etc. And usually I continue to chat with the patient while performing the adjustment. So it takes a minimum 10, 15 minutes to do an adjustment, and I typically try and see around 5 patients per hour. It's critical to understand that restriction is not the mechanism of action of the band or any other bariatric surgery for that matter. What the surgery does is allow a small meal to satisfy for a long time. Adjustments are not a burden. Adjustments are a delight. Adjustments allow us to customize this band to a particular patient and that at a particular individual at any particular time. Chronic disease management needs lifelong care. Adjustments are just part of that lifelong care. When we look at the types of bands that are being used today, we've seen almost 100% conversion from the 10 centimetre and VG bands across to the AP bands. And today I'm going to only talk about the filling characteristics of the AP bands. When does a surgeon choose a large band versus a small band? The typical decision is made in theatre. when the surgeon can see how much fat is in the area. Big men with a lot of abdominal fat are very much more likely to require the large band, whereas smaller women with gynoid patterns of obesity are likely to require the small band. Now, when we look at surveys both in Australia and internationally, about 70 to 80% of patients are receiving the APS, or the standard or smaller band. And many have found that this band works very well. Patients who are large may need a larger band, but there is some data developing, and many practices are finding that there's an advantage using the standard or small band for usual practice. And the reason they're doing that is that there's a feeling that there's a lower number of adjustments to get people into the green zone if you select your band carefully. And there's also a feeling that the larger band may not produce quite the same weight loss in smaller patients. So there is now a feeling that, well, if you can use the APS, then you do that, but in big patients, you use the other band. Hopefully we'll have more data on that selection process. At the moment, let's leave it up to the surgeons while they're in the operating room. When we look at the fill volumes of these two bands, you'll see the 10 centimetre and VG bands there, but I've highlighted the APS band and the APL band, and these are figures that I have over many hundreds of patients, and once they're settled in the green zone and more than 12 months out, the APS patients have an average of 5.3 mils in their band with a standard deviation of just over 1. Therefore, most of my patients have fill volumes when they're satisfied in the green zone between 4 and about a 6.5 or 7. When it comes to the APL band, the average for my patients beyond 12 months is 8.6 with a standard deviation of 2.2. So most of the patients have more than 6 and less than 10.5 mils. You can see that the action zones for these bands are fairly critical, and I think if you think about your own patients, you'll find most are probably in similar areas. Certainly I've looked at other practices and they're just the same. It's interesting that when we look at the intraluminal pressure, and this was some beautiful work done by Paul Burton, it shows, this figure shows the intraluminal pressure of the band when the patients are in the yellow, green and red zones, and the pressure in the band, this is the intraluminal pressure that the band produces, is 20 to 30 millimetres of mercury when they're in the green zone. And it's interesting that that corresponds to exactly an average of about 5.3 with that standard deviation that we've found for our patients. So it looks like the band is critically working on the pressure that it provides on the stomach. Now, what are the suggested maximal fill volumes and fill volume ranges for these two bands? With the AP standard band or small band, the maximum fill volume is 10. The volume at surgery is usually about 3. Suggested fills early on are usually 1 to 1.5, but very soon we get down to 0.3 mil increments. The large band up to 14 mils. I must say I've never had 10 in an APS band or 14 in a large band to date, but the average volume at surgery is around 3 to 4 mils, and the suggested volume adjustments at least initially 2 to 3 mils, and subsequent adjustments at 1 and then down to 0.5 mils. It's really important when you look at those figures on the last slide, when you look at the action zone of the band, to go very cautiously when you're in the action zone of the band. So when you're in the 5s for an APS or when you're in the 7s and 8s for an APL, think about reducing the volume, the size of your adjustments. So when you've got a patient in the action zone of a band, above 5 for the APS band or above, say, 7.5 for an APL band, make adjustments small. Make them small, because a large adjustment can have a large effect. Now, some practices and some surgeons put the band in slightly differently. They do different things with fat pads, etc. So you may find that your average volume is slightly different. It's worth knowing, because you'll know what the action zone for your patients is.